Hey everyone, it's a continuation of the EMS Action Items. This is for May of 2021. You're going to see some new mandatory fields that have been activated in the EPCR software. The first one is the respirations. The reason this was activated is because it was brought to my attention that it is required in trauma that a respiration rate, rhythm, and quality be obtained on a patient in trauma prior to leaving the scene. The second mandatory field that was activated is weight. The reason behind that is because it's good practice and good habit to estimate people's weights, number one. Number two, it helps with medication administration on pediatrics. And number three, it helps the quality management team review your reports to make sure that the accuracy of them, to make sure that the contraindications or indications for not using something or using something were followed correctly without having to send a message to the provider. About signatures, we need to try to do our best effort in obtaining a patient's signature every time we're able to. If the patient is not able to, due to unconscious or a significant biohazard, we understand that. But in those cases, please try to obtain the nurse's name and have them either sign it or get their initials and put that in the signature field. It's extremely important that we do this. Wanted to take a minute to talk about EMS 17. And high acuity calls. We've gotten a lot of really good feedback from everyone in the field, and I appreciate all the effort you're doing to make this a successful operation. When it comes to whole blood opportunities, our paramedic discretion was added into the protocol, and I think now we're all starting to think about it a little bit more. I wanted to give you some feedback. We had 4 survivors that were given whole blood opportunities that may have not survived had they not gotten whole blood. So congratulations on those. You guys are doing great. I do want to add a little bit of clarification to the EMS 17 as far as when it comes to alerts. The intention was not to have EMS 17 be notified for every alert, sepsis, etc. It was really only for high acuity calls or times that you need another set of hands there, and another set of eyes, and potentially more medication or more blood. That is the intention of EMS 17.
Hey everybody, this is Dr. Roach. I want to talk about the protocol app use on scene. So everyone asked for a protocol app several years ago. We created that app for you to help you to make your jobs easier and better. So when you go on these high acuity calls and or pediatric calls, use the app to verify medication doses. And I suggest you even do that en route to the call. That'll get your mindset on where you should be in terms of dosing. And then anything you have questions with on scene, there's nothing wrong with looking at the protocol app to kind of refresh your mind and make sure that you don't miss any important points of the call.
You always want to try to obtain the patient's phone numbers, and I know in every case that's not practical, but I just wanted to give you guys some history on why we do this. Part of the CAS accreditation standards is that we have communication with the patients, and that goes for medical billing. That has to do with patient outcomes, and it has to do with the overall satisfaction surveys that they receive as part of the accreditation standard. I know that can be kind of scary to think about. Possibly the person might not have positive things to say, but I would like to put your mind at ease and say that currently we're at 98% satisfaction rate in this department right now. So your patient care and the satisfaction is not a concern. It is a concern that if we don't get phone numbers, we're not able to reach out to them to set up meetings of cardiac arrest survivors or medical billing issues that we have, or just overall outcomes that we can feed back to the field.
So collecting the demographic and contact information isn't just about surveys and metrics, as the lieutenant just referenced. It does provide other opportunities, such as cardiac arrest reunions. On the morning of the 25th, Broward General hosted a reunion for a cardiac arrest survivor who has no neurological deficit. We refer to that as having a CPC score of 1. It's an extraordinary outcome. It took an entire large group of people in order to happen. In fact, it was a great example of the chain of survival that we've always talked about our entire education and throughout our career. It started with early recognition by the family member of the cardiac arrest victim. Shortly thereafter, Dania Beach lifeguards showed up, performed CPR, and then defibrillated with an AED. Therefore, after that, our personnel showed up, took over patient care, transported to the hospital, and cardiac interventionalist, along with their team, completed care. 3 weeks later, the patient was released to a rehab facility and currently is going to have a great outcome and prognosis, it appears.
Everybody, it's Dr. Roach here talking about the chest pain / Stemi protocol, and really want to give you the highlighted items. So the three main things that we can do to decrease mortality is to get that EKG as early as possible. We set the benchmark of less than 10 minutes. Once you have the EKG, identifying the Stemi. So when there's ST elevations, and especially when there's reciprocal changes, which is reciprocal depressions, that indicates there's a Stemi, and then we want to transmit that EKG to the PCI facility. The reason why this is important, what does the hospital do with that EKG? When that EKG comes in and we see a clear-cut Stemi, we then activate the cath lab prior to your arrival. So the interventionists, the nurses, all of the supporting staff all convene in the cath lab so that when your patient arrives, we can then facilitate them and transport them directly to the cath lab. So that's the rationale behind it. Even though when you arrive, you'll get the facility will get another EKG. That's just part of protocol, but it's not delaying the care and it's not delaying their cardiac catheterization. The last thing is the aspirin. I want to say aspirin actually decreases mortality, so it's a very important medicine. We have to make sure that we give the aspirin en route. I want to talk about the criteria for Sepsis Alert, which is the QSOFA criteria. So those are in the app, and I encourage you to look at the app on any patient that you come on that has a fever or if there's a concern for infection. Look for the three things: hypotension, which means systolic blood pressure less than 100 or MAP less than 65. Altered mental status is number 2, and number 3 is tachypnea, respirations greater than 22, and or end-tidal CO2 less than 25. So it's very important to put end-tidal CO2 on these septic patients because, as we said, when they're tachypnic and breathing heavy, they're going to blow off the CO2, and that's an indication of a serious sepsis or even septic shock. So QSOFA is positive. What do you want to do? 1, you want to alert the receiving facility. This is a sepsis alert. And number 2, you want to administer the 1,000 milliliter saline bolus en route.
I want to try to provide some clarification on the CPR form, specifically the AED use tab. When you arrive to a cardiac arrest, this section of the form should only be selected if an AED was applied prior to your arrival, who it was applied by, and whether or not they defibrillated. Once you've obtained that information, it is absolutely imperative that you provide that to the AED coordinator via email, Michael B. Olay. Last month, we talked about ECG documentation and how important it was to not only get a snapshot of all ALS patients and upload that to the monitor, upload that to the PCR, but also to provide an interpretation behind that strip. We've seen a dramatic increase in the snapshot of 4-lead and 12-lead and attaching to the PCR, so congratulations, good job on that. But there is still some area for improvement on the interpretation. It's extremely important that you interpret the rhythm so that way when the reviewer is reviewing the report, they understand what you had. This is another way for the quality management department to track Stemi alerts and significant rhythms as far as trends. Like we had trends a few months ago with refractory VFib and VTAC, and these are the ways that we're able to track them is when you guys do the interpretation. Talking about the Zoll pads and the puck use. Overall, I think that we've understood a little bit more clearly on what is required to allow the Zoll to work for you and to help you on these cardiac arrests. I will say that we're working on a video series set right now that will be uploaded to Target Solutions in the library that will allow you to be able to look at short little clips on how to change to CPR mode, how to change pads versus filtered ECG.
I have a hands-heavy update for you. As of approximately a week ago, the department was awarded a matching grant of roughly $26,000. We'll have to go through the bureaucratic processes of procuring the money, but we should be able to put hand-heavy bags on all detail units and frontline response vehicles in the next coming months. On top of that, tentatively, it's scheduled for this summer into the fall. We'll be doing hand-heavy training